Okay. Good morning, everybody.
Good morning, sir.
Good morning, sir.
And we will start here. And before we discuss on to neglected or malunited talar fractures, uh, let me give you an idea of today's case. Yes, definitely you would need gastrocnemius lengthening in this patient, and patient requires to go for the fusion of ankle joint. In foot and ankle, it is now established. Initial days when I got graduated, I was told that any problem in foot and ankle, you need to go for triple fusion. So now it is like as long as possible, as far as possible, if you are able to salvage a particular joint, that is advisable in foot and ankle. So yes, TTC fusion is an option, but is a young patient, and we would wish to salvage his subtalar joint. So a simple ankle fusion with lengthening of gastrocnemius should work in this case, and there is no need to sacrifice a functioning subtalar joint. That essentially was done in that patient. I'll put in a picture, post-op picture of that patient where I've used screws plus a plate. So now coming to neglected talus injury. So neglected means either absolutely untreated or poorly managed or overlooked. This all category of injuries, they fall onto neglected injuries. And so far as talus is concerned, like ankle, you have here early presenting patients, you can think of going ahead with the reconstruction, where reconstruction or revision would be together with the osteotomy and sometimes with the bone graft. So that's one part of the treatment. If the arthritis has not set in either into ankle or into subtalar joint, this is what you would do. Well, if the arthritis has set in, it's a very, very late presentation, then you may go for a fusion. It could be fusion of subtalar joint, fusion of ankle joint, or fusion of both ankle as well as subtalar joint. And very off late, the replacement has also come in vogue. So that is total talus replacement. So we will be talking about all this. By and large, whenever you are approaching any neglected case, then you're looking at the age and activity level and occupation of the patient, comorbidities, duration of the malunion is very important. The deformity which is present is very important. Status of soft tissues, quality of the bone, these are general factors. But for talus, we need to note whether this patient has got AVN talus or not, and what is the status of the joints, whether the joints have gone into arthritis or not, is what you need to do. You need to look for. Uh, so these two are important points of significance when you talk about management of neglected talus fracture. Very important aspect of neglected talus management. Suppose you have a neck fracture of talus which has resulted into malunion. Most often than not, this malunion is into varus, because there is the most common combination, if you see in the talus, is on a medial side. So the sustentaculum tali, it thumps itself onto the talus on the medial aspect of talus, which generates a lot of cases with medial combination. So the malunion would be in varus or in dorsiflexion. So whenever you're doing a reconstruction, it is important that the medial column of the foot gets shortened. Unless you lengthen the medial column of the foot, if at all you try to correct the varus at the heel by doing corrective subtalar arthritis, correct arthrodesis, the patient would have a varus which is maximally at the midfoot, not at the hindfoot. So this is one very, very important point which we all need to remember. There would be varus in a malunited talus, but we must make sure that this varus is at the level of neck or at the level of subtalar joint. If it is at the level of the neck of the talus, then over and above doing corrective subtalar fusion, you will have to do osteotomy with the destruction of the medial side of the talus, and we need to put in a graft inside. So going forward, we are going to see the cases. So with this basis of management of malunion talus, whether you're going to go for reconstruction, you're going to go for reconstruction plus osteotomy. So revision fixation, reconstruction with osteotomy, fusion, or total talus replacement. The cases are based on to this kind of management, and we'll go case based, right? 2 points I'll stress upon. It is that status of the joint, which is very important for talus malunion or non-union of the talus, which all are the joints involved. And salvage of at least an ankle joint is deemed. So sometimes you have arthritis of the talonavicular joint, you may require fusion of talonavicular joint. Arthritis of the subtalar joint is very common, you require fusion of subtalar joint. If ankle is good, try to salvage the ankle. That is a message. So the most essential joint in the ankle and foot is ankle. The next would be talonavicular joint. So any procedure you try to salvage this joint. Okay. And then talking about avascular necrosis of the talus. When there is avascular necrosis of the talus or many such cases, you may need to go in for MRI to look for the status of the body of the talus, because that is very important. If the body is not viable, your salvage procedure may not be useful, and then you may have to revert to a fusion than to going ahead with the salvage. Now, what all are the management options? As I said, it is revision fixation plus or minus osteotomy, ankle fusion, subtalar fusion, ankle plus subtalar fusion. One more fusion would be talonavicular fusion or total talus replacement. So by and large, we all know that the management of this neglected hindfoot cases mainly is into this kind of options. So we'll go with the case examples, which would cover all this kind of uh, cases. Okay, so this was a 25 years old male who had a trauma before 3 months, and his trauma was neglected. He had swelling, persistent pain, and uh, when CT scan was done, it was like a fracture uh, of talus with some combination on a medial side. Now, can anybody, is that a body fracture or is that a neck fracture?
Body fracture, sir.
Hmm?
Body fracture.
Body fracture.
So how do you define that the fracture is a body fracture or
The
this
line
fracture is a neck
posterior to the
fracture?
lateral process of talus.
Okay, perfect. So it is the lateral talar process, which is the one which tells us whether it's a body fracture or it's a uh, fracture of the neck. The fracture which is anterior to the lateral talar process is neck fracture, and fracture which is posterior to the uh, lateral talar process is body fracture. So 3 months old, do fusion or would you go ahead with reconstruction? And if reconstruction, what particular approach? $25 old male, 3 months. Would you all revise?
So both the ankle and the subtalar joint looks normal. So probably the best way to go with is revise.
Yes, Dr. Hari. And if you are revising, then are you going to use which approach? Obviously, for talus, you always use a double approach,
Yeah.
a medial and a
And a
lateral,
lateral.
always a double approach, right? So similarly, this patient was approached. See, remember that the medial approach is meant for you to visualize the articular surface of talus, which articulates with ankle. The lateral approach is meant to visualize the subtalar joint reduction. So a medial and the lateral, anterolateral and medial utility approach. And this is how the malunion was there. Very carefully, you have to put in an osteotome. You may first start with the caver, put in osteotome, do the careful osteotomy, and you see, this is how I have been able to manipulate the fragment, and then the fixation was done. And this is from the lateral side. I think that is the one which you see from the, yeah, this is the lateral side, and you're able to get the good on-table movement with restoration of the articular defect. And this is how the final post-op picture looked, and it went on to unite with a normal function. So early case of this kind of malunion, one should be going ahead and doing the revision, and revision should always be considered. Obviously, this is a difficult proposition, but more and more revisions we do, more and more we'll be able to really get through.
Did you use
Another
bone graft there,
case,
sir?
yeah. So if you find the defect, and defect was found at the level of, not at the level of the articular surface, but the defect was found under the articular surface. So you take in a bone graft, you can take bone graft either from the calcaneus, you can take a bone graft right from the distal end of the tibia. You can take bone graft. If you need more bone graft, you can go ahead and do proximal tibia bone graft. Typically, for a fresh talus fracture, uh, you need a strong bone graft. I don't go to the iliac crest, but what I do is I take proximal tibia bone graft in such a manner that I remove the silver of cortical bone, and the thick cancellous bone I shape in such a manner that through which I get a very good hard chunk of cancellous bone, which I immerse into the fracture site. Now, this was a 50 years old male who had a road traffic accident, and this was the X-ray, and it was treated as contusion. You see, there is still a soft tissue swelling. Patient is not able to do routine activities. Now, it was at the end of 5 months that this 50 years old male was reasonably active, father of a doctor, came. And so CT scan was done again in this patient. It's a body fracture with the fracture line traversing from distal lateral to proximal medial. And this is one of the very, very important view when you are dealing with the neglected talus injury, which gives you the idea about where are you going to put the screws and how is going to be your trajectory of the screw placement. So this where the CT scan picture. Again, I went in with two approach and did the revision with the bone grafting. This is the my frayeur going into the articular surface of malunion, and with this frayeur I am trying to manipulate the fracture, and then it was revised with the filling of the bone grafts, cancellous bone grafts into the spaces. And
बिल्कुल नई
ultimately,
नई
I got
कहानियां
to
पता लग रही
finish. Yeah. So yes, these are new kahaniyas, obviously, but non-union talus would require freshening and bone grafting and fixes. And when you do freshening of the talus, obviously you're going to lose some length. And so for that, you may have to use a bone graft. Pure cancellous bone grafting is what would be required. So till 3 months, 5 months, 6 months, 7 months, if there is no set arthritis, one can go in and revise this fixation and do the correction. So this is also very important that when you're doing such a revision, you should be using fully threaded titanium screws in a position mode, because you don't want to, you really do not want to compress. And so fully threaded screw, which is a titanium in variety, which you can later on follow it up with MRI if required. So titanium screws, which are used as a position screw, should be used whenever you have a non-union or malunion of talus when you're doing late reconstruction. Another
So
case,
regarding the number of screws, is there any rule how many screws that we should use minimum?
there is no such rule. You can use, and any configuration is accepted for talus fracture. You can put in two parallel screws, you can put in two cross screws, you can put in posterior to anterior screw, you can put in anterior to posterior screw. By and large, in trauma situation, we would always like to fix a screw starting from the smaller fragment and
To the
going
larger.
into the larger fragment. So if you have a kind of a situation where you want to compress a posterior fragment to the anterior fragment, you with the posterior fragment being small, you may like to put in posterior to anterior screw. But whenever you are putting a posterior to anterior screw, you should be very, very much watchful. Biomechanically, it is a very strong screw, but you don't have that window of opportunity to put in more screws from posterior aspect. Most often than not, I've seen people putting the posterior anterior screw from the dome of the talus, which always rubs with the ankle articular surface, and patient develops ankle arthritis. So you have a very narrow margin through which you pass this through. You have to go just by the side of FHL, never medial to FHL, because the medial to FHL is neurovascular. So you just have to retract the FHL. It is uh,
Lateral.
just by the side of FHL that you have a window through which you put in a posterior to anterior screw. And if you have a Herbert kind of a screw or a headless screw, it is always better to be used from posterior to anterior. Now, this is a very, very important case. And this is the case which taught me a lot. And let me show you that how I got caught in this case. Now, this was a 25 years old male who had a fracture dislocation talus in African country. And then they just applied a slab saying this is a contusion. This guy came back to India, and it was like 4 months when he reported to me. And this is how the it was a fracture dislocation talus. And obviously, you're going to get the CT scan. This was the CT scan picture at the end of, and you see the whole body of the talus is rotated and is out of the subtalar joint. And this is at the end of 4 months. You have a fracture dislocation talus. So, and these are the coronal, semi-coronal view, and you can see that the whole body of the talus is dislocated from the subtalar joint. And this is the challenge at the end of 3 months, that you have to do this reduction and you have to bring this into the normal position. So how would you proceed for such a case? And is there any trick described in the literature to reduce this? And the problem with the talus fracture is that most of the talar articular surface is an articular surface. You cannot put your joystick into the articular surface. Otherwise, you're going to damage the cartilage. So For such a case, obviously, you're going to need double approach, you're going to need extensive dissection, you're going to need distraction with a femoral distractor. Any thoughts? How are you going to reduce this?
Joystick it with the K-wires, the distal fragment.
Yeah, joysticking it with the K-wire, yes, but then you see on the lateral side you have a big articular surface
Yeah.
which articulates talus with the lateral malleolus, and obviously you're going to do the osteotomy, but to bring this here,
Put in
so
a friction.
yeah, so you're going to put in a distractor, but
Yeah.
you might have to put in a distractor between the tibia here and calcaneus here. So you may need to put in a local hinterland distractor to really get the length. And you might have to do the soft tissue release to get this thing. And there is a method described in the literature which is called as natural delivery method. So natural delivery method is a method to reduce unreducible body dislocation. And how often we have found this when we are doing, even in acute case, acute fracture dislocation talus, many times we are not able to reduce that body back into the mortise. And I have taken 3 approaches. Sometimes a posterolateral or posteromedial approach is required. I mean, that may be a small approach, obviously, will be required. And when you want to, and you, whatever struggle you do from pushing this body from posterior to anterior, you may not be able to really deliver it back. So the method which has been described in literature, which I have used successfully in many of my cases, is that you put in 2 parallel K-wire which are not aiming at the dorsal articular surface of talus, which articulates with the ankle, and which are not violating the subtalar articular surface. So your wire, they go, or one wire or one T-handle would also work, one T-handle with a Sanspin would also work. So you put in that right into the anteroposterior center of the body and into the mediolateral center of the body. From the approach where you see that the fragment is seen in front of you, you put that joystick into that fragment and give distraction, and then slowly pull this fragment out into the mortise of the ankle. This is called natural delivery method of reduction of the body of the talus. So anyway, I had planned to go ahead with double approach. The first thing I did was I put in a femoral distractor. I was prepared to go for the fixation, bone grafting, and osteotomy. Everything I had planned. And you see, with this natural delivery method, I could bring the dislocated body fragment back into the mortise. And once you do that, it's always advisable that you put in 1 or 2 uh, uh, wires which fix this body fragment with the calcaneus. So then you make this stable, and then you try to reduce the other fragment over it. Obviously, medial malleolar osteotomy and all this thing you require together with this. So this is how it was reduced. And I uh, uh, fixed up the medial malleolar osteotomy with a plate and a screw, and I kept this wire which was passing from calcaneus to the body of the talus subtalar. Yeah, this wire was already kept in place, and I
Excuse me,
had
sir.
this kind. Yeah.
Sir, I have tried to use the femoral distractor in a couple of cases with distal tibia fractures. I don't have the AO femoral distractor. It is from an Indian company. I have tried to distract a lot, but I am not able to get the distraction. Sir, is it the quality of the distractor is wrong, or if I am doing something wrong?
No, I don't think that the quality of distraction. This is also an Indian distractor which I've been using. So it is not that, but sometimes uh, you really need a good soft tissue release together with the distraction. So, and sometimes you need a local hinterland distractor. See, suppose you're talking about the subtalar joint when you're doing a subtalar fusion. I'm going to show you the video at the end of this session about a TTC fusion. Now you want to open a particular joint. You will need to do a lot of releases. I mean, subtalar joint you want to open, you will have to cut the introsseous ligament. Otherwise, you may not be, whatever you struggle you do, you with your strong hinterland also, you may not be able to open it. So localized specific distractors would be required. And sometimes I have found that more you distract, more trouble you are into. So sometimes you have to just relax the distractor and put it strategically into the position. So this is how I ended up doing the reduction of the dislocation and fixing it with fully threaded screws, and one wire was kept to maintain the body reduction with the calcaneus. And this wire usually I remove at the end of 3 to 4 weeks. Now, but all said and done, this case, do you expect that I had some problem? And while doing the fixation, I had a terrible problem. I struggled for about 2 hours doing this fixation. Any guess what must have gone wrong? Or in retrospect, looking at this pictures, do you see that what struggle I must have had? And have you ever thought that this kind of struggle uh, you can really get? So any
Putting the
guess?
screws, putting the screws from the distal to the proximal frame.
No, it was not that. It was
Sir, a
something.
plate,
I'm sorry.
plate could have been applied, sir, because I feel there is some sort of.
No, so no, the screw plate, whatever I fix, I had tremendous problem in fixation of something.
Medial malleolus.
Yes. So I could not close the medial malleolar osteotomy. I did extensive release. In fact, doing that release, I also put in one small cut into tibialis posterior, which I had to repair. But I could not close the medial malleolar osteotomy. And so I thought that probably it is the medial structures which are very tight. So I also did release of the capsule of talonavicular joint. I did the pi crusting of the superficial deltoid ligament. I struggled for 2 hours to close the medial malleolar osteotomy. And ultimately, what I had to do, I had to paint drape iliac crest. I had to take a graft from iliac crest. And if you can see carefully, here is the graft which I have put in to close the medial malleolar osteotomy. I had to put in a plate plus screw.
So did you use a sword
Are
for
you
the
able to appreciate this?
Yeah. Yes, sir.
Yeah. So I had to put in, now can you see here? This
Yeah.
is the, maybe my next, yeah. So this is the graft which I had to harvest and I have to put in. I never faced such a problem. So I was really worried that why is that I was not able to close the medial malleolar osteotomy? Was that uh, that 4 months of fracture dislocation with varus positioning
Yeah.
made my this thing very much tough. But then you see, post-operatively, I mean, when I remove the stitches, you can see that still this foot remains into slight varus, right? So then I thought that, okay, I must take some international opinion of some legends who. So I got an opinion of one of my mentor in US, and he said, you get a post-op CT scan. And you confirm whether your reduction is proper or not. And I said, what reduction? He said, reduction of subtalar joint. So Stephen Rammelt gave this opinion. And so I get a post-op CT. And I felt everything was all right. So he said, no, probably your subtalar joint is slightly subluxated. You revise everything. And I had no courage to go back and revise it. I said, let's see. Then there was another opinion. And he said that because there is a virus, you need to stretch out the tissues and you give serial corrective cast. And otherwise, if it doesn't come around, you may have to go in for extensive medial release and lengthening of all the tendons on the medial side, FHL, FDL, and tibialis posterior. So I went in with corrective, sequential corrective cast, and that this cast, mind you, were the routine cast. I went on doing it and I could correct it. And ultimately it united. Now, do you feel that the subtalar joint is unreduced here?
No, sir.
It looks good.
Yeah, it's not reduced. So, so ultimately I told patient that, boss, you may need something else, but let's continue with this. So plaster was removed, the K-wire was removed, and the fracture got united. And this is the end result. Obviously, he has some restriction, his restriction of inversion, eversion, but good dorsiflexion, plantarflexion, and some restriction of inversion, eversion. He has gone back to his routine work with some virus, which is definitely there. So I'm sure he's going to come back for this virus because ankle cannot tolerate virus. But this was one case where I definitely had to struggle a lot to close the medial malleolar osteotomy. Do not know it was a mild subluxation at the subtalar joint, which mandated me to do this, or was it the soft tissue contracture which did not allow closure of this osteotomy? Any thoughts, any suggestions, any
Sir,
comment?
may I ask a question, sir?
Please, please, please.
Sir, looking at the primary CT and the X-ray, I think there is a severe subtalar destruction. So we could have gone for a subtalar fusion with a corrective varus osteotomy, something like that.
Yeah, so now there is a method described where people do. So John Cohn does this for a very bad fracture dislocations. He go in and he does a primary subtalar fusion plus reconstruction of the neck femur fracture. So that also people have been, and there are articles showing this kind of management done in the talus fracture. So obviously, if doing a subtalar fusion in this case would also have not helped me to close the osteotomy.
Sir, obviously.
Yeah. So, but it was like a terrible struggle on table, and I thought that this is what you should know, that in an old case, sometimes if the soft tissue contraction, and today I feel that it must be a soft tissue contracture, which has not allowed my reduction, reduction of the medial malleolar osteotomy.
How important is the role of deltoid here, sir? Because you're probably that contracture
Very
would
important.
have, yeah.
Very important. You cannot cut the deltoid.
Yes.
You cannot cut the deltoid. At the most, what you can do would be just pie crusting of the deltoid. Right?
Okay.
So this is what we do routinely when you have a varus deformity at the ankle or at the and you're doing a supramalleolar osteotomy. You do open wedge medial osteotomy, and that time you will have to reef or you will have to tighten the lateral ligament, and sometimes the deltoid ligament do not give you a leverage to really open the osteotomy. That time you may have to do pie crusting of the deltoid ligament. You can lengthen lateral ligament in a case of valgus, but you cannot lengthen the deltoid ligament. It's a very strong ligament, very important ligament. So only pie crusting of deltoid is what you can do here.
Pie crusting is done in
So,
superficial or both superficial and deep?
no, it's like you know the area where your deep and superficial deltoid is. You don't go to the posterior tibiotalar part of the deep deltoid ligament. So you go with your deltoid ligament, which superficial deltoid ligament and a deep deltoid ligament in form of anterior tibiotalar component of it. So you take in your 11 number knife and you put in multiple incisions and you manually you apply the corrective force. That is how you do it. You cannot excise the medial malleolar fragment because if you're not able to close the osteotomy, you will not be able to put in your suture anchor and your sutures into that. So only option for you left out is to put that fragment back and make sure that it unites with the original bone.
Sir, how much of the
Now,
gap was there in the medial malleolar osteotomy, sir? Was it
so that
shortened because of
gap,
the graft, or could have been lengthened it to correct the virus?
how can you lengthen it? It's a oblique osteotomy at the level of the shoulder of the ankle, and you're not able to close it. So the gap was like a wedge-shaped gap. So I don't remember exactly, but it was like 3 to 4 wedge on an outer aspect and about 1 wedge on an inner aspect. So a triangular wedge from the iliac crest. I think you people are able to see my hand.
Yes, sir.
Yeah, a triangular wedge was taken where the outer aspect of the wedge was a cortical bone and the two inner side were a cancellous bone. So it was like 3 to 4 millimeter. But this is a cancellous bone. You need, when you fix the medial malleolar osteotomy, you need to fix it without any gap. So here in gap of 4 or 3 on an outer aspect definitely would lead to non-union of the osteotomy.
So I have one more question, sir, in that particular thing. So we are actually doing an opening wedge osteotomy of a medial malleolus. That's what's the eventual end result of your fixation.
Yeah,
So,
it was an opening wedge osteotomy of
okay,
medial
so
malleolus.
this medial malleolus might be poking on the anterior surface of the talus, leading to the limited dorsiflexion. You know, whether my thought process is correct or
No,
not, I
this
don't know.
medial malleolus is lying on the side, is not lying to the front. No.
Okay, sir.
No. Now,
At least that way,
one
does it
more.
block the eversion?
I'm sorry, come back,
Does
please.
it block the eversion, sir, in this continuing the same question?
Yes, it would. It would. It would definitely. It would definitely. The another malunion which you find, which is not so common, is a dorsiflexion malunion. And if you recollect, I had posted a case in our group where patient had subtalar arthritis following a talus fracture, and patient had a big spike onto the united portion of the neck and body junction. And this, in such case, if you all recollect, you need a excision of that dorsal exostosis for malunion of talus. So obviously, these are less number of cases, but if malunion talus has got a dorsal osteophyte which is blocking the ankle dorsiflexion, you just go in and excise that. You recollect that case we had put in our group.
Yes, sir.
Yes, thank you. Another case, 18 years male who had trauma 2 years back, was treated as sprain and it was a misfractured talus. Had pain, difficulty on walking, more on uneven ground. This is the common complaint of patients with subtalar arthritis. And look, this is a malunited fractured talus with subtalar arthritis. Now, obviously, your management plan would be to do corrective fusion. Now, what all are the difficulties or how this ST fusion is different? You see, the body has gone posteriorly So the posterior facet of the talus lies here, posterior facet of calcaneus lies here. So you really have a limited contact between the articular surfaces. So how would you manage to do subtalar fusion in such cases? Anybody? You got my point? Why the subtalar fusion in such talar malunion is difficult? Because your articular surfaces are not in contact. And one is displaced posteriorly, one is displaced lying in the normal anterior this thing. Professor Hari
Sir,
or Ganesh?
sir, when it is obviously it is malunited, we might have to break it with an osteotome and get it back into position. But I'm just thinking, how would the ankle get affected when we do that?
Have certain more viewpoints, sir. I think there's an extensive soft tissue contracture. There's a dorsiflexion deformity of the neck of the talus, as well as the calcaneus is shortened, means that there is some amount of tendoankle shortening also. So I think this needs an extensive soft tissue release, and I'm sure that this will be a struggle in intraoperatively.
Yeah. So you need extensive soft tissue release, and still you would struggle intraoperatively because this is a anteroposterior blast of the talus body. So must be a vertical thrust injury which has shattered the talar articular surfaces, and then there are fragments lying here, fragments lying here, and so the whole talar body has elongated. And this, as I could recollect, was one of my early case where I never anticipated that such a issue can ever happen. And I think I also struggled doing this. The another trick is, and that was a fantastic point you brought in, that what effect happens with the, what happens to the ankle. So normally, when you do a tibio-talocalcaneal fusion, you like to push your talus back over the ankle so that the lever arm of the tendoachilles is helped. So you always push your talus back onto the ankle. So this position will not, or of talus will not alter the ankle biomechanics. Yes, definitely, as somebody said, this is a dorsiflex talus, is definitely going to affect. So if at all you are able to jack this up, it is good. If at all you are able to reduce it, it is good. But it is a big struggle getting this into the position. The most important maneuver I have learned for reducing this is a Hintermann distractor. So you put in Hintermann distractor, 2.5 mm wires, one into the talus, one into the calcaneus, do extensive release. And with this wire in, you manipulate your talus and calcaneus with the wires and Hintermann distractor. With the power of the Hintermann distractor, you can really manipulate, and once you get a proper position, you can push in a wire to fix both tibia, talus and calcaneus, and then go ahead with the fusion. So obviously you need a long incision with a wider release for such cases, and fusion of all three subtalar joint is deemed with addition of bone grafts, because you, whatever struggle you do, you may not be able to really put that talus and calcaneus into contact, because there are also some malunited fragments which has gone posteriorly. And this is how you would work for such a case. You may have to add the bone graft, and look at this. I really struggled to get this underneath, but I had a reasonable contact here, and I packed up bone graft here, and I made sure that I do fusion of anterior, middle, as well as posterior subtalar joint in a corrected position. So this is really a challenging thing when you do subtalar fusion post-talar malunion. And then serial broadened views are helpful for monitoring your subtalar fusion. And this is how I like to get 10, 20, 30, and 40 broadens imaging for monitoring of my subtalar fusion. And it is one of ST arthritis is most common but most challenging following talar malunion. So any comment, any thoughts onto this?
Sir, what about the height of the talus in such cases? Would you like to bring it back and do a TTC fusion instead when you see that there is the height of the talus is reduced?
See, why should you be doing TTC fusion? Because ankle is good. You try to salvage the ankle. But these are the cases, and practically speaking, for me, any malunion case, be it be midfoot, be it be ankle, be it be talus, calcaneus, I always like to take the uh, X-rays of the opposite side in a similar kind of rotation, and that is going to be very, very much vital, right? So you uh, make your patient stand and look at the talar declination angle, the height between talus and calcaneus, look onto the opposite side, and that gives you a rough idea that how much restoration you have to do. Doing a fusion of ankle is not justified because subtalar joint, if it is bad, you can always go ahead and do fusion, but try to salvage ankle is the message, very clear cut message.
So
Now,
continuing that
question is,
particular
can
question, how will we assess the ankle joint assessment, the cartilage assessment? Do we take a MRI or a ankle arthroscopy, something like that?
you can take MRI, you can do ankle arthroscopy, but by and large, if you look at the injury X-rays, you come to know that this patient will have no involvement of the ankle cartilage during the primary trauma, and it was only at the subtalar joint. And so that patient is going to have subtalar arthritis. And with your X-rays, you also know, and with your clinical examination also, you know that the ankle articular surface seems good and there is no arthritis of the ankle. It's
So the
not that
height of the
difficult.
talus is decreased here. So is there any chance of a limb length discrepancy or?
Yeah, there is a chance of limb length discrepancy. So you try to restore it with whatever best you can do. The limb length discrepancy is not that great for you to, give heel lift, but yes, some shortening always results.
Do we do anything to the TSR here in this case?
Yeah, in such a case, you have to do gastrocnemius lengthening and very, very rarely open tendo-Achilles lengthening.
Nothing.
And you see the case in which I struggled, I should have done tendo-Achilles lengthening. If you recollect, my last plaster for that patient was not into an ideal position. There was an equinus. See this? See this? Though these plasters were not given under general anesthesia, but there is an equinus here. That talus case, fracture dislocation talus case. So, pilon fractures, ankle fractures, bad talus fractures, all these fractures, patients are left out with some kind of uh, tendo-Achilles stiffness or tendo-Achilles shortening. So that is what a study is being undertaken by Johns Hopkins University by my friend John Cohn, that for all such complicated talus or a calcaneus injury, why not to do at the time of fixation, primary fixation, why not to do tendo-Achilles lengthening? So that seems something like an overkill because you really are not able to judge that how much tightness of the gastrosoleus you are going to be left out when you do these surgeries. But that is what they have taken as a prospective study that because these patients do have at the end of healing some degree of tendo Achilles contracture, why not to do release of tendo Achilles at the beginning? That is what they are studying. And I'm keenly looking forward to their results. Any other question? Okay. So then question is, can you do subtalar fusion with retained implants? And this was the case where we could get out with implants in situ, and we could go ahead and do the subtalar fusion. Sometimes it is possible, sometimes it is not possible. And this is what I wanted to show you, that a patient who had varus and corrective subtalar fusion was done still looks into a bad position. And this was a picture taken of one of my young patients where I was ashamed of my own result. Now, this were the X-ray pictures. I did triple joint fusion of the subtalar joint. But this patient, such a patient, they have, and I was not happy with this corrective ST fusion because varus malunion of the neck cannot be corrected at subtalar joint. It needs correction at the place where you had this kind of deformity. So it requires something like this. So you have to go in and do the osteotomy from the original fracture and put in your lamina spreader, distract the medial column of the foot and put in an tricortical iliac crest graft into this defect. Unless you do this, you will not be able to correct the varus, which you can see here at junction of the forefoot and midfoot, you will not be able to correct. So mind you that correcting only hindfoot will not work in cases of talar neck malunion. You will have to do corrective osteotomy of the talus neck, or you may have to do osteotomy distal to this fracture, or you may have to do some corrective fusion distal to this fracture. But that will only help you to correct the medial column shortening in the foot. So that is one point which I wanted to share with you so that what mistakes I have done in the past, you don't do it. 21-year-old male had a polytrauma, fractured talus, operated with assistance of medial malleolar osteotomy before 16 months. And there was painful restriction of movements at the end of 16 months. And the reason, as you see here, was some sort of low-grade infection. Surgeon removed medial implant. Pain was persistent. And then this was the situation when he came to us, and there was an issue of vascular status of talus, stainless steel implant, so that you cannot do MRI. And then question was whether to do single surgery, double surgery, removal of the implant to be done or not, and what approach to be taken. We took a extensile lateral approach with a fibular osteotomy, and we dissected the ankle and did ankle fusion and salvaged the subtalar joint. And this is how it went on to heal. So post-talus malunion arthritis of ankle would be most challenging to manage, but you need to make sure that whatever joints are bad requires to be fused. Whichever joint you can salvage is to be salvaged. Implant requires to be removed for ankle fusion. You may get out with the implant inside too when you're doing a subtalar fusion. A 26-year-old male had a polytrauma, had a compound fracture dislocation talus. This was the images at the end of 24 months post-index surgery. There was a draining sinus on a medial side. The first stage, debridement, implant removal, and antibiotic beads. And the next stage, we went in and we did TTC fusion because herein there was an infection and subtalar joint was also bad. So tibio-talocalcaneal fusion was required, and ultimately the sinus healed. And this patient went on to do good. So talus malunion can also lead to arthritis of both ankle and subtalar joint. Then it requires TTC fusion. And if there is an infection, then you need a stage procedure for infected cases. Another case, now 52 years old male, 2 years of talus malunion. And with this kind of picture, he was referred to us. At surgery, we ended up excising the talus completely. And then the question was that how to bridge the defect. And so we took in fibular stud grafts, and you can see the nail inside, and the grafts were positioned around the nail. And you can see one more graft here, anterior and one posterior. And this was then compressed. And later on, we developed our own method of doing a fusion when you have a defect. And this is what we labeled as bamboo hut technique of uh, defect management at tibio-calcaneal and tibio-talocalcaneal fusion.
Do you put the
And
nail first or the grafts first?
I'm sorry. No, nail is always first. And
Nail
when
first.
you are putting the nail, when you are putting the nail, you are keeping your lamina spreader
Okay.
and you're putting 1 or 2 K wires so that you make sure, and this K wire should not be parallel, should be in such a manner that they should not be altering the nail, and they should be maintaining the height of that area. Otherwise, the whole purpose of not giving shortening in a young patient will not be served. And then this is what I do with the fibula stud graft. I parts a K wire and then a fiber wire suture. I tie it over itself and leave these two ends, and then put it at 12 o'clock, 3 o'clock, 6 o'clock for a right-sided patient, and put in a lower end of fibula here. So this is and then it is compressed, because if you see design of my straight nail, you put in a small nut inside, and with your screwdriver, when you put in a screw above the ankle, below the ankle screw is in an oblong hole. So when you tighten the nut, the screw slides in and you have compression at the ankle joint. So this is what is being demonstrated, that you put in your screw into an oblong hole and then putting a nut, and you tighten the nut. This would get compressed, and you also then put in tie sutures, with no specific pattern, but you tie sutures with this grafts in place. So this is how the defect is. You'll put in a lamina spreader. You see this lamina spreader to maintain the defect, and then you put in the nail and put in your grafts and tie the fiber wires with each other. So this is how you do it. And then it goes on to healing. Right. So in absence of allografts, TTC fusion can be done with bamboo hut technique. And this is what was published in Techniques in Foot and Ankle journal. Case 8 of neglected talus fracture, a dentist of 24 years. Now this was 3 days post-trauma. He was doing his studies into a private medical college where they just capped this compound fracture dislocation talus like this. They did not do debridement for 3 days. They just put in the dressings. And then at the end of 3 days, he was forced to come down to his hometown. So when he came back to his hometown, the surgeon, after 3 days, put in the talus back and did the debridement and put in external fixator and some few K wires. Now this got infected, and surgeon went on doing the debridement number 1, debridement number 2, K wires were removed. Patient was toxic. This was the picture when I pitched in, and then I thought that I should not rely, as told by our seniors, never rely on anybody else's debridement, do it yourself again. So I went in and I did a thorough debridement, and then I ended up with excision of lower end of the tibia, that of complete talus, and this is how the excised bone looked. And no question, the question was how to bridge such a big defect. And this defect obviously was bridged with the Elizarov apparatus. And we did corticotomy at the top and started lengthening. We had to lengthen about 12 centimeter. When it reached to the docking level, we went in and did a bone grafting once it united. And these were some flaps which we had to do going forward managing this patient. Now, once this unites, we have some few Elizarov experts here. So what is the time period you give brace to this patient? Any thumb rule for that? Any Elizarov expert here? So I just wanted to know from any Elizarov expert that once you have a docking, once you have a union, how long do you protect this patient? Okay, anybody? Protection, when you do the corticotomy lengthening and you get the union, how long do you protect this patient in a brace? I was under the impression that you need to protect double the time you got the union. Am I right? Prabnor, Hariji?
This is what I have been taught.
Yeah, so I think, so I gave a brace to this patient for 15 months. When I think I have not immobilized him for a lesser time. And you can see a brace lying here. And then it was given for 15 months. And then I asked him to go back in action. But 4 months after the removal of the brace, he came back to me. And he said that I've got some repetitive fall and instability at the level of union. And this is what a weight-bearing X-ray looked like. So any guess what has gone wrong here?
Subluxation.
Sir, maybe it never united with it.
Yeah, but it never seemed like, you see, yeah. So it was like a fibrous union or not. No, it was a solid union. We dynamized the apparate fixator and removed it. And then he was doing all well. And
So
3 months,
a CT in such
4
cases
months.
to be sure about the fusion.
I'm sorry?
Should we get a CT in such cases in which we know that it is complicated before allowing them to go out of the brace?
No, but then all this thing, you dynamize the apparatus, you ask them to walk without, you keep them sometimes in the hospital. This boy was kept in the hospital and was dynamized, and then, okay, we uh, got correct idea that, okay, this is united. And because the parents and this unmarried boy, they were not at all keen to go ahead with amputation. So now it is like 4 more months, and it was like 2.5 years that he had fibrous union or non-union of the tibiocalcaneal fusion.
So
Now,
would,
what are the
any
options
kind of
now
fusion?
in your hand? I'm sorry?
Would any
Just
kind
look
of
at the
fusion
gate.
into the joint?
He drifts into valgus. Look at the gate. I'll run it again. He drifts into the valgus when he puts a weight. See this? And he limps. Yes. So what was the question, please?
Sir, would any kind of an implant into that fusion would have helped after removing the Elizaro probably like when
Yes, I was also thinking the same. Yeah.
See, this is what after this case, I've started believing that once you remove the release, and there are many centers who practice that once they remove the releaser out, they put in a small plate or some kind of an implant inside. No, but this, looking at the skin condition here, the then time, you would not have really ventured implant, putting implant there. But now what? He is not ready for another Elizaro. He's not ready for amputation. He has vested, he has invested his so many months or years for this fracture, and
ETC.
it's a frank non-union. So what would you go ahead
ETC.
and what would you do?
Intramedullary
So,
nail from the calcaneal to tibia.
so intramedullary nail, you would be able to pass only 2 screws, one into the horizontal plane and one into the posterior anterior plane when you put in a TTC nail, and 2 or 3 screws above, 2, 3 screws above. So that doesn't give you a kind of solid fixation. Maybe you can put in one mission nail kind of a screw, but it doesn't give a solid fixation into this. And with just, loss of soft tissues here, you really want some good implant to put in. And obviously, Elizaro was out of question. He said, "Sir, do anything, kill me, throw me, but I am not ready for Elizaro." And that is what happens, after one trial of Elizaro for about a year, and then immobilization for another 1.5 years in brace, really psychologically kills the patient.
Anterior approach.
Yes, Ganesh?
Anterior approach. Put a plate from
That's
tibia.
the only part of leg which looks good.
No,
Yes, sir.
but anterior approach, going and putting a plate from tibia, where would you put the plate? Because immediately you will encounter the midfoot.
That is the problem.
Your plate will not be able to fix the calcaneus. If it is a tibia, midfoot, and calcaneus, you will not be able to pass the screws.
So can we go back to his latest X-rays?
Parth? Yeah, this were the X-rays. They were the latest X-rays. Okay, let me show you what I did. So this were the latest X-ray, obviously. So I went in with the lateral approach and put in a lateral TTC plate as a lateral tallow calcaneal fixation, and I could put in this many number of screws into the distal fragment and into the proximal fragment. This is how. And I also put in the bone grafts, and it went on to unite. So any comment on to this? This is Arthrex plate, which is Arthrex lateral TTC plate, where you push in 4 screws into talus, 5 into calcaneus, and 4 into tibia. And you have a screw which goes from the plate to really compress plate to the talus. Herein there was no talus. So this is the kind of plate I used. Any comments?
Additional bone grafts was placed around this plate also.
Yeah, I did put in, and this is united. This is solidly united.
Yeah.
Now, the story doesn't end here. Now, this was like about 9 or 12 months. He went back and he completed his dentistry also. And then he came back a week back, complaining of pain at the lateral border of the foot with cons and callosities. Any thoughts? What is going wrong here?
Nerve. Sural nerve.
Yes. So this plate being a
Lateral.
locking plate, I could not really you know, uh, and you are always afraid of a valgus. So I actually fixed him into little virus, and that is what is seen in this Salzman view, that the calcaneus is into virus, and that is why he is overloading his lateral border and he has developed cons and callosities. So what next?
Some accommodative insoles.
Offloading brace.
Okay, so accommodative insoles given, it did not work. What next?
Osteotomy for the calcaneum now.
Yeah, corrective osteotomy, sir.
So which osteotomy of calcaneus would you do? And where would you do? Would you remove the implant and do the osteotomy?
No, I will not take the chance.
So yes, you need to do osteotomy of calcaneus. You cannot do Dwyer's osteotomy, or the screws would come in the place. In the way, you will not really go and become very courageous to remove this plate at this juncture for 9 months. So the best thing would be to do a slide plus tilt. So you do the osteotomy at this level and slide it. You need to do plantar fascia release on a medial side and then slide this laterally and angulate this so that you can really get a correction. And this is what he is being advised, and he is just waiting for this. So this is what should be the plan for him. So Elizarov lengthening case may fail even after 15 months of bracing. Is that the message I want to give to all of you?
So was he weight bearing when during the brace, sir?
Yes, absolutely. Yeah, it's a long PTB brace with which
Yes.
you walk. And
Yeah.
that is what all Elizarov guy advised.
Yes, sir. Yeah.
Case number 9, 26-year male had a polytrauma with extruded talus. He was treated with tibiotalo-calcaneal fusion before 1.5 years or so. And he came with this X-ray picture and with the complaint that since 2 years of surgery, he has never ever been able to stand or walk. Anything you have to comment? Why is that he's not able to stand or walk?
Unsound fixation and inappropriate bone grafting at the joint.
You're absolutely right, because young patient cannot really stand and walk onto two fibular stud graft, and there's three screws just trying to fix it. So what next?
CT scan.
Okay, CT scan, 2 years patient unable to walk. These are oblique views, and already lateral approach was taken, and there was a lot of fibrosis there. So
It completely fill in with bone
so
graft.
what would you do? Yes, Professor Hari?
Sir, remove all the fibrous tissue and put in a bone graft and do fusion of both level at the level of ankle and also subtalar.
Right, it is a tibiocalcaneal anyway. So you do bone graft. What fixation would you do?
Probably supported with both nail and a plate.
I think I talk of the time where the nail was not available. Anyway, but when you're putting a nail, are you not afraid that out of these two grafts, it seems, except here, except this place, it seems that the grafts have consolidated. Except at this place, it seems that grafts have consolidated. So do you want to disturb that? That was the thought process in my mind.
Extramedullary fusion, extramedullary implant for fusion.
Yes.
Extramedullary implant for fusion, sir.
Okay, let me show you what I did. The challenges in this case was maintaining the length, taking a kind of approach, and TTC nail was not available. And so I went through the medial approach. And through the medial approach, I saw that there was definitely a poor consolidation in one graft and destruction was done. I took in a fibular bone graft, repaired the graft, put in multiple fibular graft and a strong plate on a medial side, bridging tibia, going right up to the midfoot. And it went on to, and a lot of bone grafts here, it went on to unite. And I had a video of this patient's gait, probably I missed it. But I think sound fixation is a must for solid TTC fusion, is the message I wanted to convey through this case.
May I
Now
ask one doubt? Why a tibiocalcaneal plate was not applied, sir? Madam.
Yeah, that's a good question. You know what happens that on a medial side, you have a lot of important structure that traverse between the tibia and the calcaneus. You have all your neurovasculars going like that. So you have to have a kind of a bridging plate. You cannot go ahead and put in a plate here. On a lateral side, yes, it is possible to put in a plate. So all TTC plates are lateral TTC plate, not the medial one.
It appears a bit in varus in that AP view. Was that right, sir? Not really. Okay.
Maybe unless we take the salesman view, we really will not know about it. I saw him after a year or so after the surgery. He was quite happy walking normally. Now, this is again a very important case. Okay, 26 year, no, this is not the one. 26 years old male, trauma before 1 year, treated with open reduction, K-bar fixation, implants removed, pain persistent, restricted movement of ankle, referred with MRI with suspected AVN. And yes, he had this scars, and then he was sent to us with the suspicion of AVN following a trauma. What is wrong here? Anybody? You have an X-ray in front of you.
There's a neck fracture of the talus.
Neck,
With
yes.
some amount of
Malunited neck.
forefoot adduction. That's a medial column
So
shortening.
what? So malunion of what?
Neck of the
Alan-
talus.
Alluvial
Neck
of
of
the
the talus.
with ABN.
Okay. So MRI was done, which literally ruled out the AVN. And this is what was the fracture. So what is typical about this fracture? When you have such a non-union, what approach would you take for reconstructing this non-union? It was like after a year.
As you previously told, a dual approach.
I'm sorry, dual approach.
Dual approach, medial and lateral approach.
But, you know, would you be really able to access, this fracture? The trajectory of the fracture is dorsally, it is proximal, but plantarwards, it is coming right here at the talonavicular joint.
So osteotomy,
this is
medial utility approach.
osteotomy, sir.
Yeah, osteotomy we'll have to do. The question is which approach would you take? And for
Probably medial
such
would be
kind
more
of cases,
helpful.
for such kind of cases, you should be taking an approach which you take for a navicular fracture or or for a fracture which involves talonavicular joint. So it's a straight dorsomedial straight approach is what you need to take for such injuries. You see, we have to reduce it here and fill that up with the bone graft. And this is the obliquity of the fracture. So such a case, obliquity of the fracture, and look at this fracture. It's very, very close to the talonavicular joint. And this being the obliquity of the fracture would define your approach. So so simple lateral view. This was after 1 year post-surgery that this patient was having. So for this, the approach which you need to take is a dorsomedial approach, which many times we take for navicular fractures. So this is how it was approached, and the osteotomy is easier from this approach. You cannot go with the medial or lateral side. You have a fragment lying into dorsiflexion. So put in a K-wire, opened up the fragment with the osteotome, and this is a very small fragment. And your thought process always goes on whether I'm going to salvage the talonavicular joint or not. And I opened this up and pushed in the bone graft, reduce it, put in a multiple K wires which were not through the talonavicular joint, and then pushed in the screws which were fully threaded screws and pushed in the bone graft from the iliac crest and went on to heal. So change of the approach would require for a small fragment where you have a non-union of head and neck of the talus.
How do you get the
39.
rotation of the neck in such cases?
So you put in either a transverse wire through the dorsal aspect of the fracture, or you put in two oblique wire. And with this oblique wire, you are able to control the rotation of the neck. 39-year-old male with road traffic accident. I think you've seen this case with the lost talus. I have shown this case. That was my first case where I did total talus replacement. This is how a cement spacer was put in, and an extra fixator was put in. And then 3 days down the line, relatives came with the talus. They found out it at the place of accident and they wanted me to put it back. This was after cleaning, and so I decided not to put it back. I got the CT scan of this talus as well as the opposite side talus and got a 3D printed total talus implant done. This was a trial model, a plastic one. There were holes for anchorage, there were holes for extraction and impactor. And this is how the final processes came in with an anterior approach. I removed this spacer and put in the talus. This were the fiber wires. I wanted to pass it through the articular surface of, with a needle to pass it through the articular surface of navicular and tie it at the talonavicular joint. This was to put it on a lateral side. And this is how it was put it in. And this is my the longest survived case. It is still surviving. It is now 3 months, 3 years that I've done this. And then thereafter, so many such cases of talus replacement. This was another case. This was how the talus was implanted. Now I also started getting the model, plastic model 3D reconstructed of the affected ankle. And so before and only I try on this model, putting my plastic model there, whether I would need +1, +2, 0, or I would need 0, -1, -2, something like that. And accordingly, I get the trials prepared. I've also experimented by formulating the lateral and the medial ligaments, but it is said that it is not required. So it also needs a good consideration whenever you have a case like this. Probably the last case, neglected talus fracture. 23 years old male, road traffic accident, had a crush injury of the foot. Debridement was done and he was referred to us at the end of 3 weeks. This were the x-rays when he was brought to us. We got the CT scan and you see that there's a huge combination at the medial part of the talus. Have I shown this x-ray to you? Have I shown this case to you?
No.
No. Okay. So what next? So I did surgery number 2 in form of, because as our seniors have taught us that don't rely on somebody else's debridement, do it on yourself. I went in, I did the debridement. This was at the end of 3 to 4 weeks. I put in an external fixator. I put in K wires for fibula. I excised the dead pieces of talus on a medial side. And you see, this much part of the medial talus got excised. And then I put in a cement spacer with antibiotic impregnated cement, and vacuum assisted dressing was kept. But this is how the wound could be closed. I put in a vac here. It was a quadrangle frame I made, and this is how it went on to heal. And 3 vac followed by skin grafting. And now it was 8 weeks, wounds healed, fixator off. What would you do for this patient? So this was a trans calcaneal wire, and the two
Your voice is not.
I'm not getting your voice.
Am I audible and is my scene, my screen seen?
No, sir.
sir.
Hello?
For the last few minutes, we are not able to see you, sir.
Yes. a minute. Okay.
We can see you now, sir.
Yeah. So it was probably sort of poor connection. Are you able to see my screen?
Yes, sir.
Yes, sir.
Yes, sir.
Yes. Okay. So what we were discussing is that it is now 8 to 10 weeks post trauma. Everything has healed. And what kind of definitive fixation would you do for this patient? Patient is not keen on getting uh, fusion. So, any thoughts, any idea? Prabnur,
Maybe you
Hari,
have
Doctor.
total talus replacement in this case.
I need a proper intraoperative culture to make sure that everything is sterile. So I think we
Yeah.
have to do
So
a stage.
you can do one or two aspirations and send the aspiration for culture sensitivity. And if that is negative, you can always think of going ahead with total talus replacement. But I did not think about total talus replacement for this patient because total talus replacement is an experimental surgery. The one which is artificial has its own limitation, vis-a-vis one which is natural. So let me show you what I did in this patient. So the problems were loss of 55% of talar body and how to replace this loss. And so I went ahead and got an allograft talus of as much matching age as possible. So this allograft was transported to Baroda from Bangalore, and I removed the spacer. This is how it looked like. And then I cut the allograft talus to the matching size. And this is how the allograft looked like after cutting it. And then I put it back and I matched it at the level of the ankle because I knew that at some place I'll have to compromise. The patient is going to require later that subtle fusion, but at least if I am able to salvage the ankle, that would be great. And I also got the length of the fibula, put in a syndesmotic screw, put in a lot of bone grafts here. Then the problem was, now, so this is how a body fragment was converted into one. And then problem was, there was complete loss of the dorsal aspect of the neck of the talus, how to restore this loss. And then I put in multiple cancellous bone graft, punched it and put in a uh, uh, abgel over it and push in one screw, whatever best I can put in over this. And this was the final result. You see, this is well united, and that's the lateral view. And these are the movements. And he very recently sent me this video of he driving a scooter with his uh, fiancee. So that's how, we could salvage ankle joint of this young patient. So allograft talus could also be an option to salvage at least one joint.
Any particular care in handling of allografts? And what?
Yeah, so once it is transported into a cold chain, and then once you get it, you have to use it preferably within 24 to 36 hours. And once you bring it out of that container, you have to wash it thoroughly. And once you wash it thoroughly, you immerse it into a gentamicin impregnated saline solution. That is what you need to do.
Sir, you have said you have selected the best age possible in terms of allograft selection. Is there any criteria for that, sir?
No, the criteria means we do not have such a facility like the Western world where you give the age, you give the size, that preferably the same size of tallograph would be available. But you can even cut the allografts which are available in the Western world. Herein, you don't have that option. So a matching allograft is what you would try to get to the best possible matching. So that's what I asked. I asked them that, okay, if you have some adult patients, tell us, it would be helpful.
Have you anytime tried total allograft talus replacement instead of this total talus?
I'm sorry?
So have you any time tried this total allograft talus replacement, sir, instead of?
No, I've not tried, but one of my fellow Dr. Ajoy, who is in Ramaya, he has put in total talus allograft, and his long-term results are awaited. Even John Corn, he also puts in allograft as total allograft talus instead of total talus replacement. So it also acts as an inert spacer. So he is doing that. Long-term results are awaited. In Western world, you can have a matching size of the defect, which is not possible in Indian scenario. So that was about neglected talus. And let me go ahead with talking about neglected Lisfranc injury. Now, when you talk of neglected Lisfranc injury, uh, there is no reconstruction in this area. So you decide arbitrarily that by end of say 4 weeks, 6 weeks is a time that I will not go in for the reconstruction or revision fixation. I would go ahead and do the fusion. The reason behind this is that these joints are very small joints. They are very, very small joints, and they have a very small cartilage area. And if you have such an injury which is neglected, already the cartilage is lost, cartilage is without the lubrication, it looks dead. So that is one reason. The second reason is that uh, these are non-essential joints with hardly any movement. So in fact, they contribute into the stability of the first, second, and third rays. So going ahead with fusion doesn't matter at all, because otherwise also they are the joints which move the least. So due to this essential reasons, that for a Lisfranc malunion, or when you have a Lisfranc uh, missed Lisfranc, the management is in form of fusion. By and large, management is in form of fusion. The question comes whether you have to do fusion in situ or you have to do corrective osteotomy. So let me show some of the cases. This was at the end of 4 weeks. Diagnosis from these X-rays. Anybody, Parth?
Sir, Lisfranc ligament injury with medial cuneiform fracture and cuboid fracture also.
That's right. But then we are focusing about onto Lisfranc injury. So you feel there is only there is no Lisfranc injury in this case?
So there is Lisfranc.
Yes, sir. There is widening of the first TMT joint, sir.
Yes, Nikhil, perfectly right.
Sir,
Anything else, Nikhil, you
I need a
find?
lateral X-ray too.
Okay, but in an AP view, this
Sir,
is probably
yeah.
Nikhil. Dr. Nikhil,
Yes, sir.
are you happy with the second metatarsal?
No, sir. There's
Yeah, there is a second TMT, which is also called
Laterally
displaced.
subluxate.
Yeah,
yes,
now
sir.
this is the lateral X-ray.
So is this a weight bearing X-ray?
No, I don't think this is, yeah, this is a weight bearing X-ray. What you see here is a platform. Yeah, it's a weight bearing X-ray. So are you happy with this bump here?
No, sir.
Doctor? Yeah, so there also is, and this, if you have a closer look, you have increased first and second empty space. You also have subluxation of the second. So missed Lisfranc injury. Now what? So no question that you would need fusion of first and second tarso-metatarsal joint as it was done here. And look at this. The Lisfranc screw is almost always put first, and then you do your fusion with a plate or whatever form. You can do it with the screws also. So Lisfranc screw is to be passed first. So high index of suspicion can only help in avoiding. Yeah.
So, this was 4 weeks old, so it was missed, obviously. So, usually, whenever we see these Lisfranc injuries, so we cannot operate on them for minimum maybe 2 or 3 weeks because of the swelling. And in younger patients, you only advocate that we should bridge the joints instead of fusing them. Sir, what difference does it make at 4 weeks? Why did we fuse it and not bridge these this particular Lisfranc injury?
So initially it was like 4 weeks for me
Yes, sir.
to go in and do fusion. Now I have gone beyond 4 weeks. I uh, uh, reconstruct it up to 6 weeks. But mind you, whenever I am taking this decision, my patient is always informed that I am going to open, I'm going to look at the status of the cartilage, and I'll take a call. If it is a pure ligamentous injury, like this, without a bony injury, I'm sure of going ahead and doing a fusion.
Okay, sir.
It is for the ligament injury that if you talk to Chris Cordier, whose paper made that revolutionary thought process was transformed to all of us through the Chris Cordier's paper. So in a personal communication, he says that my whole contention was about the ligamentous Lisfranc or subtle Lisfranc in athletes, where these ligaments, they do not really heal and patient is always having problems. So for these kind of cases, why not go with primary fusion for this non-essential joint? So if it is a ligament injury which comes late, no question I'm going to go for fusion. If it is a traumatic injury in form of a fracture or Lisfranc fracture disorder, we may still try to salvage it for 6 weeks. And you know this plantar ecchymosis, weight-bearing X-rays, all this thing would help you in precise analysis of Lisfranc injury. You should be using CT scan generously. Now, this was a 24 years old male post-trauma. This was 3 weeks post-trauma. And you see here, there's a bony flak. This has separated. There's a second TMT injury. I think there's something going wrong here also. And that's a lateral view, and CT scan is telling you about second and probably the third. So delayed intervention for Lisfranc injury was done in this case. And look, when I opened, the cartilage looked, I mean, this was the capsule ligamentous flap, but the cartilage looked reasonably good. And if it looks reasonably good, you reduce it back into the position that second and third, and you fix a Lisfranc screw. That would be followed by a bridge plate fixation of second and third. And herein at the end of 3 weeks also, I did not do fusion. I did the reconstruction. And then fourth was fixed with the intramedullary K-wire for So by 3 to 6 weeks, if it is a Lisfranc injury with a good cartilage, I might try and salvage the joint. If the uh, joints are bad, or if it is a subtle Lisfranc injury where Lisfranc ligaments have gone, I would go in for late cases to go ahead with a fusion. Again, this was 7 weeks presentation of male 39, skin condition was okay. So what next would you do? Get an CT scan, severe combination of the bases of second, third, fourth. These are the CT pictures and 3D reconstruction, neglected injury. We're going to go ahead with diffusion of the first and second, second and third, and a soft fixation of the fourth TMT with a K wire. Now, this is like 6 years post-trauma painful malunion following a Lisfranc injury. Now, what difficulties would you encounter when you are reconstructing this? And this is definitely a very, very tough case. Sri Ganesh?
So I think obviously that's a very tough case, sir. And we need a proper planning by a CT scan. I expect that there is a both medial as well as lateral column shortening. So we like to open up, we like to fuse the first TMT, second TMT, third TMT, and I'm not sure about the fourth and the fifth, but obviously this needs a lengthening of the medial as well as the lateral column.
Yeah. So sometimes if you are not able to lengthen, you should be doing symmetric shortening of both the columns. But the most problematic thing here is that there is a huge amount of plantar fibrosis in such cases, and you definitely need to plan your incision very nicely here. And for a medial side, you take a medial approach, which is just into the center of the medial border of the foot. You may take an approach between second and third, third and fourth, and you don't do the fusion of fourth and fifth. That always is treated with an excision arthroplasty. And this kind of a deformity, and at the 6 years when this patient comes to you with a lot of fibrosis, long-standing malunion, you just, this is what I tried. In fact, this was the case where I remember that I struggled a lot to correct this, and fourth and fifth were stabilized with just a soft fixation. And this is the case which I already showed. It was a diabetic patient, trivial trauma and deformed foot, which was operated with the screw fixation, failure of fixation at the 2 months. Obviously, this was to happen. And this has a rocker type of a foot. So you would need a double osteotomy, a biplanar osteotomy, a plantar based wedge removal in a sagittal plane, and uh, a medially based wedge in a coronal plane is what you would require. And CT scan, this is how a medial approach, and you're taking a wedge which has got bases plantarwards as well as medial one, and this is the intraoperative correction. Then you either fix it with the beam screws and a plate, or a plantar plate, like I put in a plantar plate in this case. Also did corrective procedure for the second, and this went on to unite beam screw for the second, plantar plate and bone grafting for the first tray. So all these 5 cases were neglected Lisfranc cases of different duration and with varied age group. So how is your decision making based? So decision making based is based on to 5 criteria: duration of the injury, age of the patient, activity level, presence of neuropathy, and status of joint on exploration. So if the duration of injury is up to 4 to 6 weeks, and it's a bony Lisfranc, bony plus ligamentous Lisfranc, you can try to reconstruct it. If it is beyond 6 weeks, no question, you go in and do fusion. This is what is my algorithm to treat this kind of cases. And if it is a pure ligamentous Lisfranc, beyond 4 weeks, I'm going to go ahead and do the fusion. Age of the patient, younger the age, you try to do reconstruction. Very old aged patient, you can give an orthotics and get out without doing anything. Same is for the activity level. Neuropathy, obviously, you're going to go ahead with carrying out a longer, stronger combination fusions. And status of the joint also matters. If the joint looks bad, you need to go in and do the fusion for these cases. So that was about neglected or malunited Lisfranc. Now, any question on to this, or else we move on to the next topic? Okay, no question with regards to
Sir, is there any
Miss
difference
Lisa.
between the post-op protocol for fusion or for bridging?
Yeah, for fusion, you would like to, if it is done for a neuropathic midfoot, you would like to immobilize them double the time than the normal fusion. Otherwise, for a fusion or for a fixation, you immobilize them for about 4 to 5 weeks and then start mobilization. Unless it's a very long standing fusion, like I showed in one of the case, then you may like to, immobilize them for about a week or two more.
Sir, what is the actual difference in functional outcome between fusion and fixation? Is it the one and the
No
same?
difference. No difference. No difference whatsoever. Only thing, if you're doing fusion and unless your implant impinges, you don't need to remove the implant.
So can I ask a question, sir? In all cases of Lisfranc injury, can I blindly go and fuse the joint?
So that is where the whole debate is going on in the world. So there are surgeons who believe in primarily fusing every Lisfranc injury. And there are surgeons who go in and try to reconstruct the Lisfranc injury. So that is where the whole debate is. So what I have settled down is looking at the status of the cartilage. I take a call, even if it is a fresh Lisfranc, I take a call based on to status of the joint intraoperatively. Anyways, you're going to open because you don't want this capsular ligamentous structures to get interposed. So you need to open the Lisfranc injury. So whenever you open it, you distract it, you see the status of the cartilage. Sometimes you're gone with the notion that I'm going to go for fusion, and you find that cartilage is good. You may just reconstruct. It really doesn't matter if you fuse this joint. These are non-essential joint. And the movement between this joint is like 3 degree, 2 degree, 1 degree. That is the movement. So you can definitely go in and fuse this. No worries. So that brings me to our next session on to perifibular pain. Now, this is one of the very common problem we encounter in our practice. The patient is having pain in and around fibula. And there are so many important structures coming into this area, and we really fail to differentially diagnose that what is the reason of pain. So this talk essentially is that how can you differentially diagnose the various reasons for perifibular pain. So first you try to get an answer whether this is a pain which is originating from local cause or a distant cause. And then Unilateral involvement definitely tells you that probably this is a local one. History of dominance of distant symptoms, positive distant clinical examination, negative local clinical examination, and positive investigation will tell you that here is a case where a pain is coming from the spine. And then if it is local etiology or if it is systemic etiology, that is what you want to come down to before you really point out to the differential diagnosis. So systemic involvement, you will have bilateral involvement like in the heel pain, like in the posterior heel pain. There will be history of involvement of other joints, positive general examination, and there will be diffuse tenderness on clinical examination with positive investigation. So when you have a case where you have a diffuse kind of tenderness, this definitely is because of some kind of arthropathy, and this will have a similar kind of involvement on the opposite side. So bilateral involvement with this kind of diffuse swelling and tenderness would definitely suggest some kind of arthritis. And the last question which you are to answer after your clinical examination history is that what must be the local etiology giving rise to this perifibular pain? So it's all about your index finger. Either you ask your patient to put in index finger at the most painful site, or you put in your finger and palpate the tenderness. You put in your fingers anterior, lateral, posterior, inferior, superior to this fibular region and then come to the diagnosis. So suppose you have your swelling tenderness, which is into the anterior zone, into the inferior zone, into the posterior zone. How are you going to go ahead? So tenderness at all this spot suggests you some kind of infective or inflammatory etiology. If there are constitutional symptoms, spasm, markedly restricted movement, that means there is an infective etiology. If there is diffuse swelling, tenderness seen on the same opposite side also, there is some kind of inflammatory etiology. So let's go ahead and look at the various locations which would be guiding us to the clinical diagnosis. Suppose you have pain and tenderness anterior to the fibula and there is a syndesmotic sprain. If the tenderness is between the fibula and tibia at this particular level, then if you have tenderness anterior to the fibula, between the fibula and talus, it is lateral ankle gutter impingement, like you have following the anterior talofibular ligament or lateral ligament injury. ATFL injury, it would travel from the tip of the anterior aspect of the fibula, will go right up to the neck of the talus. That's an ATFL injury and issues thereof. Sinus tarsi syndrome would be little below. And if there is a OCD of lateral talar dome, you will find tenderness over the lateral aspect of the talus. And some kind of talar neoplasm will have continuous tender area over the whole talus. And then you have your certain special tests to know syndesmotic injury. This is the lateral, this is the external rotation test. And this is the instability test for ATFL, instability test for CFL, MRI, X-rays, all would help you to diagnosis. Now, suppose you have the pain and tenderness posterior to fibula. A peroneal tendon pathology would have pain and tenderness and swelling adjoining the posterolateral border of the fibula, because the peroneal, they lie directly in contact with the fibula. Sural nerve issues, you would have tenderness posterior between the posterolateral border of the fibula and anterior border of tendoachilles, and you would also have a radiating pain which would go up to the fourth and fifth toe. posterior ankle impingement, you would have pain and tenderness, which is posterior to the fibula, and at the level of talus, you will have a bony or soft tissue tenderness with impingement. And insertional tendo-Achilles issues, you know. So this is how you palpate the peroneal tendon problems, and this is how you trace the peroneal. Now this is a snapping peroneal, which you very well are able to diagnose. Sural nerve issues would give pain and paresthesia in its course. And this is how you palpate for posterior ankle impingement. This is the palpation for posterior ankle impingement. And you're putting ankle into plantar flexion to aggravate the symptoms. And then insertional tendo-Achilles issues, you very well know how to palpate. And if the location is of pain is subfibular, below the fibula, if you have a calcaneofibular ligament issue, you will have pain directly distal to the tip of the fibula. Peroneal tendon issues, you would be able to palpate the pain and tenderness under the fibula. But below that is your subtalar joint issue. The most difficult thing is to identify and differentiate subtalar joint issues from a subfibular impingement, which you get following a adult acquired flat foot. And I'm coming to that, how to differentiate. Hypertrophied peroneal tubercle, the tenderness and bony bump would be little below. And subtalar joints pathology, peroneal tubercle pathology, you know very well. If it is something like that, where you have pain, swelling and tenderness, which is diffused anterior to, below and posterior to fibula, this is a subfibular impingement because of acquired flat foot, which you must be able to differentiate from subtalar joint problem. A subtalar joint problem, you have a horseshoe swelling, and many times you find some bony osteophytes at this level. You also find tenderness on the medial side with restricted subtalar movement. But the one which is because of subfibular impingement, you have a diffuse pain, swelling underneath the fibula, anterior to fibula and posterior to fibula. And standing examination will give you the idea that what is going wrong here. And obviously, we all know that ankle sprain, we talked about it. There are so many situations in foot and ankle which can mimic like an ankle sprain. And that's what you should be able to differentiate. So this was a small talk onto perifibular pain. At one of the Viroc session, they wanted me to talk onto that. I thought it would be worthwhile to talk to you, because in our office practice, we find so many patients who come with the perifibular pain, and it would be a careful palpation, careful history taking, and careful clinical evaluation with some help of some special tests that you would be able to come to differential diagnosis. Best thing would be to ask patient to turn around in a lateral position and examine this patient. And never forget your standing front as well as back evaluation for such patients. So if you do not have any questions onto this, I'll go ahead with TTC fusion. So while I did it, the last week we took some videos. Videos were taken by my assistants, and step by step TTC fusion video I arranged, and this is how I formulated a TTC fusion video lecture. So I hope you don't have any questions with regards to office issues talk, and then so I'm going ahead with TTC fusion video talk.
Okay, sir.
So Yeah, thank you. So this is the lateral standing X-ray of this patient. Patient has got poliomyelitis and practically speaking, no power, and because she walks with this kind of thirst, she's having pain. We were taught that poliomyelitis patient would never develop arthritis. It's not so. Now we have seen so many patients who are with arthritis, and look at the way she walks. Her knee is obviously good. Then only you think of doing a TTC fusion. So position of this patient, I like to position this patient with a bump here so that my opposite limb do not, obstruct my image intensification. And I put in a bump here to maintain this foot into at least neutral or slight internal rotation. So this is how the patient is positioned for TTC fusion. And I'm marking the base. I marked the base of fourth metatarsal. This is a fibula which I marked. And your approach goes from base of fibula to tip of the fibula, base of the fourth metatarsal, tip of the fibula, and then about 10 centimeter up. Sometimes if you want to take third fibular graft, you may have to extend it here. So this is the approach. Once you mark it, you put in your bold incision, and when you put in this incision, the most important thing would be a dissection, which would have to be done with a full thickness flap. So you create a full thickness flap. Till I create the full thickness flap, I'll not allow my assistant to put in his retractor here. Full thickness entry and posterior flaps are very, very important whenever you are going ahead with this dissection. And you go on taking this up, and once you go up, you are able to reach out to the complete medial aspect of the tibia. And similarly, you create a full thickness posterior flap. This is very important because this is the area where you might even find the issues of closure, and wound issues would also be common here. So you're raising a full thickness flap, taking care not to injure the peroneal here. And you're doing a fibular osteotomy, which is in the direction of proximal lateral to distal medial. And this fibula is osteotomized at 2.5 centimeter above the tip of the lateral malleolus. You're cutting the anterior structures to the fibula. You're cutting the lateral structure. I mean, whole anterolateral structures are cut. So ATFL, AITFL is cut. You may cut part of the calcaneofibular ligament, but do keep the posterior structure so that you have to reflect the fibula down to see. So this is how I'm reflecting fibula down to see the posterior aspect of ankle. So posterior extent of ankle is seen properly by reflecting the fibula down. And look, this spike is put in at the underneath the posterior border of the tibia. I am putting 2.5 mm wires, and I'm going to thread hinterland distractor over this wire, and I'm going to distract the ankle to really clean up the cartilage of the ankle joint. And when you put in a hinterland distractor, you have to put in one wire longer and other wire shorter. Otherwise, you see myself struggling to put the hinterland distractor. I always like to punch it and then bend the hinterland distractor, bend the wires so that hinterland distractor do not come out when you're distracting the joint. And both the wires are bent and they are turned in such a manner that they will not come in the way of your distraction. And I'm going to open the hinterland distractor. And once I open it, I'll be able to see the complete cartilage. And I start scraping the cartilage with various sizes of curate, that of the ankle, that of the tibia, that of the talus. So once you have done this complete strapping, this is how it looks like. Okay, I think you did not listen to the sound which was there in this video. So let me. There is some. I'll run it again. But the most important thing is that you are.
So prepare the articular surface of ankle, that of the talus, that of the outer side of the talus where fibula will join, and here where this part of fibula will join.
So you are clearing every articular surface, a medial malleolar surface, tibial surface, talar surface, outer side of the talus, outer side of the outer lateral side of the talus, outer lateral side of tibia, because your fibula is going to join here. And you also make this fibula sliced into the half. The medial half you use as graft and lateral half you put back as a live plate.
So prepare the.
So then you start dissecting and identifying your subtalar joint. Your peroneal are going to give you the guide towards this subtalar joint. So I've identified the subtalar joint, and the next thing would be to distract the subtalar joint. And so this one wire is put into the talus, one wire is put into the calcaneus, and before distracting this, I'm going to release this distraction. So I'm going to use another lamina spreader, another Hintermann distractor, and I'm going to slide it over this 2.5 mm K wire, band the K wire, and distract this subtalar joint. So once it is positioned, you band these wires, subtalar joint wires are bent. And now I'm opening this lamina spreader. So once you open it, you are able to see into the subtalar joint and start removing the cartilage from subtalar. Sometimes if this is not adequate, this dissection, you put in a lamina spreader also and curate out all the cartilage from talus as well as calcaneus. Step is to lavage copiously both ankle as well as subtalar joint so that all cartilage debris would be washed out. After you do lavage, you proceed to drilling the articular surface, because this is the material which you really want to retain. Clearance, this is the subtalar and ankle joint cleared. Now I'm going to put in multiple drills. Now I'm drilling every possible surface, whichever I have scrapped. And this drilling is done with the K wire because it helps in retaining the graft. And this material is important for you. You want to use it as graft. And feathering of the articular surface of all these areas is done with osteotome. So multiple osteotome perforations to increase the vascularity is what you are doing. And then fix the joint temporarily with K wires in such a manner that the joint is positioned well and your K wire should not come in the way of nailing. And this is how you really take the entry for this nail. In a deformed foot, you put in an anterior wire, match it to be in center in calcaneus, talus, and tibia, and put in a vertical wire and draw it over the heel. And similarly, for the lateral side entry, you put in a wire which should be in the center, check it, And once you check it on the image that this is into the center of tibia, talus, and calcaneus, put in another wire over it and take a mark a horizontal approach with the pen. And this connection here would be the area through which you're going to put in your incision, then you put in your nail, and this is how the deformity gets corrected. And use a drain and close it over the drain. Any questions with regards to approach, positioning, preparation of ankle as well as subtalar joint for whatever pathology you want to do TTC fusion?
Sir, the entry for the nail, the incision you've made on the sole of the foot, right, sir?
Right.
Okay. I am.
And you check three views. You
Yes.
check axial, lateral, and AP. But the entry point typically would vary as per the deformity. So the best thing would be to look into the center, look to position your guide wire into the center of tibia, talus, and calcaneus in AP view, in lateral view, and then the joining of these two lines would be the place from which you will be putting an incision.
Do you do a reaming of these nails, sir?
Yes, absolutely. Absolutely.
And is it the same standard procedure that we take one nail short?
Yes, and like you ream up to 10 if you want to put in a nail of 9, you ream up to 11 if you want to put in a nail of 10.
Yeah.
So this is how it acts.
Okay.
And so what about the length of the nail? How do you decide upon it?
I mean, you put in your guide wire, you can put in a nail. You have some companies have that kind of an assembly, kind of a foot rule through which you know about the size of the nail. So you try to select a longer nail which should go beyond the isthmus. That's one important point, because they found out that all those patients where they had a stress fracture, it was at the level of the tip of the nail, and because a short nail was pushed in, there was a stress fracture. So stress rises are always at the tip of the nail. So you need to cross the isthmus and let your nail be floating into the upper end of the tibia. So in the upper end of the tibia, nail is floating. And I don't usually lock the freehand screw, which is at the tip of the nail. No, I keep it like that. I don't want to make the construct very rigid. I put in two screws above the ankle, a screw in the talus, which is lateral to medial, a screw in the calcaneus, which is lateral to medial, plus posterior to anterior. In Charcot, I'm going to put in one or two screws which are missing the nail, going from calcaneus to talus to tibia.
Does any extraarticular deformity?
I'm sorry. How deep you put in the nails? Often we find that it's sort of walking after the nail, the heel pain is there. That's one of the problems.
So if the heel pain is there, that means your nail entry is quite posterior. Usually the nail entry is at the junction of the anterior and the posterior two-thirds of the calcaneus. Your nail entry is anterior to the heel fat pad, just anterior to the posterior tuberosity of the calcaneus. If you go beyond that, then beyond more distally, you're going to encounter or hit the nerve, lateral plantar nerve. So, all those patients, if you have seen the matrix nail, which is a straight nail.
Yes, I have seen, I've used, yes.
So that
very
is a
nice.
nail.
That's one of the best.
Yeah, so that is a nail designed by me. So,
know that, sir.
in that,
used it.
In that nail, we have got a facility to do compression at ankle joint, facility to do compression at subtalar joint through the nail. So when you are compressing at ankle and when you are compressing at subtalar joint, at ankle you are able to compress to the tune of 4 to 5 millimeter, and at subtalar joint you are able to compress up to 3 millimeter. So considering this, it is advisable to when you are going to do this, both these compressions, you need to put in nail little in up to 4 to 5 mm. And so push it in. And when you do the compression at ankle, part of the nail would come out. When you do compression at the subtalar joint, some part of nail would come out. So calculate that. Otherwise, your nail should be right at the level of the calcaneus. It should not be extending below. Otherwise, there could be problems. In a Charcot, it doesn't really matter. But in a non-Charcot patient, you should not be keeping nail from. That is not acceptable.
What's the sequence of an interlocking, sir?
Yeah, sequence of interlocking. Okay, I don't have the nail in hand, but you should be putting 2 transverse screw above the level of ankle first. Then you put in 1 transverse screw into talus. And this transverse screw is in an oblong hole. So once you put in these 3 screws with a screwdriver through the nail, you tighten the nut. And as you tighten the nut, you will find that the screw below ankle would slowly go up and there will be compression at the level of ankle. Now, once you have done this, you push the transverse screw, which is below the level of subtalar joint. So that is into the calcaneus. And don't put that screw in. Just keep your drill bit and everything there. Remove the bolt. Pass one more nut through the nail, and then again put the connecting bolt and push your screw, which is there, into the transverse screw into the calcaneus. And then you tighten the nut so that you will have compression at the subtalar joint.
Right.
And the last thing would be to put in a put in the jig for a posterior-anterior calcaneus screw, and you push in the posterior-anterior calcaneus screw. And if you want, you may put in a freehand screw at the top of the nail, which is at the tip of the nail. So this is how the chronology acts.
Right, sir.
Clear? Ankle compression, subtalar compression. For subtalar compression, you have to put in an extra nut. Because you can put only 1 nut in the nail. Cannot load the second nut. Otherwise, you may not be able to compress through that nut. So you put in, you give the ankle compression, then drill for the subtalar screw, subtalar compression screw, remove the bolt, put the nut, push the nut, and then go for the subtalar compression. And the last screw would be posterior anterior calcaneus screw. So we call it a day today. If there are no more questions, we will meet on Tuesday and on Sunday. On the Friday, there's YROC. If TTC nail are not able, what other nails can be used? You can use a tibia nail, which we have been initially using. Tibia nail with Herzog band was what we were using.
Doesn't
So
give
it was
the
not an
compression,
ideal
sir.
one.
Doesn't
It was
give
not
the
an
compression. Doesn't
Yeah,
give the
doesn't give compression. See, the problem with even Synthes and Smith and Nephew nail is that these nails are to be put into the prone position or a lateral position. They are bent nail and they do not give compression. That is the problem. That is the problem.
So anytime do you encounter wound adhesions issues in TTC fusion, TTC nails? And because the marrow liquid might just come out of the opening of the nail?
So I was not putting a drain initially, but then now I've learned and I'm invariably using a drain in 1 or 2 Charcot cases, otherwise not a wound issue.
Okay, sir.
Thank you, sir. Thank you very much.
So all of you must have seen a kind of a provisional program which I have prepared
Yes, sir.
Yes, sir.
For the cadaver meeting. I thought that because you all are senior trauma surgeons with a lot of experience, I thought that we should be discussing and we should be demonstrating some few cadaver demonstration and some few hands-on. So any suggestions, any comments, any take on to that, you may put in our group. And this is just a provisional program. I feel that this all is going to take about 6 hours, and we're just keeping some few minutes as a backup. So this is going to take about 6 hours, and I have roped in a good Indian faculties, which would be helping you all in this. So any suggestions or any comments, you may please come up. Otherwise, if I don't get it within a day or two, I'll log this program.
Okay, sir.
I've roped in, I've asked Arthrex guys to help us with their syndesmotic tightrope for all 8 tables. They're going to provide us with tightrope implant, and they're going to provide us with the suture anchors for lateral ligament reconstruction plus plus internal brace for reconstruction of lateral ligament. And medial ligament, I'm just going to go for a demonstration. So
TTC nail, sir? Matrix TTC nail?
yeah, it will be almost impossible to get this. So I'm just going to show you the entry matrix.
Should be all right.
Matrix has some issues at the top. So that is not going to be, we will not be getting it. So I'm just going to myself or some of the faculty would show the entry. How do you take TTC nail entry? That is what I have included. Then I think nailing is a simple procedure. You've been doing a lot of tibia and femur nailing more than me. So no question to show complete. But we will have a nail with us, and I'll show you the chronology how to fix it.
That's what, sir. That's what we wanted to see.
Yeah, that's what we'll do. Sure.
Yeah, sure.
Okay.
Right, sir.
Okay. Thank you, everybody.
Thank
you for being with me on this Sunday morning. Thank you. Bye-bye.
Thank you for your time, sir.
Thank you, sir. Thank you.
Bye.
Thank you very much.